Hello. Hi, hi. Yeah, one second. Let me share the link on my social media portals so everyone can join. You have to create a new one. The old link has expired. So give me 5 minutes and we'll start. Let everyone add to the stream. Hi, 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 hi. Am I audible? If I'm audible, please give a thumbs up. So we'll start the class in 5 minutes. Give me a thumbs up if you could hear me and the voice is very clear. Let me post the link on my social media portal so everyone can join. Just 5 minutes and we will start the session. Just 5 minutes. Hi, hi, hi. Hi everyone. Hi, hi. No NEET PG postponement will not be there. So let's talk about ECG and not postponement. Yes. So yeah, 2 more minutes and we'll be starting the session. So to be precise, this ECG is an important topic recently, even in the INSET and also in the NEET PG exam. ECG is being asked like maybe one or two questions, not maybe direct ECG images are given, but they are asking clinically. So this ECG class, we will be discussing both the from the basics to the depth. So even first year MBBS student, the UG MBBS, even the interns and PG aspirants can understand if you guys are really poor in the ECG. And we will also discuss in depth where I have selected 20 to 25 ECGs, I guess. We'll be discussing all those ECGs which are very important, which you look in your daily clinical practice, and also you will be dealing them with your exams, in the NEET PG exam or whichever exam you're preparing. So, and yes, we'll start now in, yes, right. So the first point, whenever someone gave you an ECG, first thing I would like to say is that you don't need to panic that you were given an ECG and how I should interpret. First point anyone will ask if you were given an ECG is heart rate. So whenever an ECG is given and you are asked a heart rate, immediately what if the basic knowledge, if we have basic knowledge, and we will be looking into the number of large boxes between two RR intervals, and we will be calculating it as 300 by the number of boxes which we have in between two RR waves. So here I have drawn it as 4. So obviously we will be saying 75, and that is simple. Heart rate is 75 per minute. But my question is here, why is 300? Did anyone of you think why we are taking only 300 and not 500 and not 200 and not 1000? So here is the basics. That's where the basics comes into action. So we have to know a few basics which are very, very important. So first point I would like to ask is that how many of you know that ECG, one ECG strips, how much time it will take for one ECG strip to come out of the ECG machine? So if you could guess in the comments, please guess. But the answer will be 10 seconds for an entire whole ECG strip to come out. So 10 seconds, and if you take the entire ECG strip and if you count the total number of large boxes in the 10-second ECG strip, there will be 50 boxes. So if an ECG strip is coming out in 10 seconds and if ECG strip is coming out with 50 boxes, we have to calculate the heart rate for 1 minute, which is 60 seconds. So obviously we'll be getting how many boxes? 50 into 6 is equal to 300 boxes. That's where this 300 has come. Okay, so why I have to tell this minor basics is that medicine is everything. Medicine is everything. Why? Why is this? Why is this happening? Why we are getting this? So when you ask the question why, the medicine will be very easy, and you will learn medicine more conceptually. So this is where the 300 comes, and it is very easy when you count the total number of large boxes between two RRs, and we divide it by 300. So 300 by 4 is always 75. Then there is a second method how we can calculate the ECG. The second method is the number of small boxes between two RRs by, sorry, sorry, 1500 by number of small boxes. Again, where does this 1500 come? So when you are looking into an RR, we have two RRs and we have somewhere around five boxes now. So let me take five large boxes now. So let me take one large box, and in that large box, we can clearly see five small boxes. So one large box having five small boxes, 300 large boxes will have 1500 small boxes. So that's where this 1500 has come. So I think many of you are very much familiar with these two methods of calculating ECG heart rate. That is 300 by total number of large boxes and 1500 by total number of small boxes. But this applies, these two methods will apply only to an ECG with which is having a regular rhythm. What is this regular rhythm? We'll go there. What is this regular rhythm? But meanwhile, many of them have added. So my request is that to everyone, please download the ECG notes PDF which I have written. The link to download that PDF is in the description of this video. So download that first, then you will easily understand whatever class I'm teaching. You don't need to write any notes specifically. So we can complete the class much more faster and your time will also be saved. Right, I'll give you 2 minutes. Just download that PDF from the comment section, the link given in the comment section. Then we will continue. So far I have discussed just heart rate. Two methods of calculating the heart rate. One is 300 by total number of large boxes. Another one is 1500 by total number of small boxes. So these two methods, many of you people know, but so 2 minutes, just download the PDF. So Yeah, the PDF is free for everyone. Just download the ECG notes PDF. I think that will be the best PDF ECG notes that you will ever get, and you will understand the whole ECG in just 20 pages. I have included all the practice modules for the ECG also. So yes, if you have downloaded, just give me thumbs up. I'll move on with the class. Yes, that's great. So there is another method. So now I'll draw an ECG. So if you look at this ECG, there is an equal distance between two RRs, maybe four boxes everywhere. But what if I have an ECG of this kind? So I have an ECG of this kind where the distance between two RRs is not really the same. It can be two boxes, it can be three boxes, two again, it can be five or six boxes again. So I said we can use these two methods whenever we are having a regular rhythm. So regular rhythm is nothing but we should have the number of large boxes or small boxes equal between any two RR intervals that you take in the entire ECG strip. Right. If the number of large boxes are same in the entire ECG strip, then we call it as regular rhythm. If we are having two boxes between two RRs or three boxes between two RRs or if five or six boxes between two RRs, then we call it as irregular rhythm. So if the rhythm is irregular, we couldn't really calculate the specific heart rate because see, there are two large boxes between two RRs. 300 by 2 is 150. If there are five, there are almost 60. So which one we have to consider? Is it 150 is the heart rate or 60 is the heart rate? That's when the actual thing that comes. So in the entire ECG strip, the standard lead is generally second lead. So in a lead two, count the total number of R waves, right? Count the total number of R waves. For example, the R waves, total number of R waves in an ECG strip is 12. So multiply with 6. You may ask why we have to multiply with 6 because total number of R waves we are getting in a ECG strip is just for 10 seconds. So if we have to get it for 60 seconds, then we have to multiply it with 6. That's when we get 72. So I'll show you a module here. So let's see. Just calculate the heart rate from this ECG I'm showing on the screen. So first thing we can calculate 1, 2, 3, and half year. Total we have 4. Again 1, 2, 3, half year we have 4 again. 1, 2, 3, half year, we have 4 again. So from this, we can clearly see that between two RRs, the number of large boxes are 4, and it's the constant number of large boxes are there. So we can clearly say this ECG is a regular rhythm ECG. Okay. So regular rhythm ECG, we can calculate with the two methods that we have discussed. What will be the first method? That is 300 by total number of large boxes, that is 4. So 75 will be the heart rate. So if you want much more precise, then 4, you have to calculate number of small boxes in between them, and you will obviously get the answer. So 4 into 5 will be 20, and 1500 by 20 you will almost get 75 again. You may ask, can't we apply the third method, that is number of R waves into 6 in this normal regular rhythm ECG? Yes, we can apply. Let us count how many R waves are there. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 are there. And yes, 12 are there. 12 into 6, we almost get 72, which can be more precise heart rate of this particular ECG. Right. So let us move on to another ECG. Now we'll calculate heart rate in this particular ECG. Let's see how many large boxes are there between two RRs. So 1 and half here, 3/4 here. There are 2 here. Then we have two more than maybe two again. So two, one, two, 2.5 here. Again, we have 2.5 here. We have only 1.5 here. Then we have somewhere around here 2.5 again. So it's looking like it's not constant number of boxes between two errors. Then we can clearly say this ECG is an irregular rhythm ECG. So this irregular rhythm ECG, we need to find the heart rate from this irregular rhythm ECG. Then definitely we know the third method, which is nothing but counting the number of errors, and we can multiply with the 6. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. So 21 into 6, that is nothing but 126 per minute will be your heart rate for this particular ECG, which is irregular rhythm ECG. Right. So that's how you calculate the heart rate in a particular ECG. So next we'll be moving on to next basic point we'll be discussing is about the conduction system of the heart. So generally, whenever you're looking into the conduction system of the heart, first point we have to know. So again, here before we discuss the conduction system, we have to know few points, few basic points. Let me tell you the resting membrane potential of a, cardiac myocyte will be minus 90 MV, and this will be completely dependent on one ion, which is very very important. That is nothing but potassium ion. These are very very important for your NEET exam. So this potassium ion is most responsible for this. And whenever we study ECG or in whatever means of sources you study, one thing they will tell you is that uh, whenever there is a current or a conduction wave is moving towards the electrode, we will get a positive wave. And when it is moving away from the electrode, we will be getting a negative wave. This is right to some extent and wrong to some extent, because I will tell you why. I will tell you why when we are discussing the conduction pathway and the conduction directions, how the conduction pathway goes in the heart. Before that, let me tell you the conduction pathway. So we have an SA node here, we have an AV node here, we have an AV node here, then we have AV bundle, bundle of His, then we have right bundle branch, then we have left bundle branch, and we have Purkinje fibers. So this is what the conduction pathway of a normal heart. So whenever we have a conduction pathway of a normal heart, so this what happens is that SA node, when SA node has a property called as an automaticity because it activates on itself. So when the SA node is getting activated, definitely what happens is that this SA node will activate the entire atria, and this atria, the current moves along the atria and activates the AV node, which is present at this junction. Now AV node will stimulate the AV bundle, then AV bundle will transmit the current to bundle of His and bundle of His to ventricles via Purkinje fibers. Right. So this bundle of His is one of the fastest conducting system in the entire heart. That's why we can see the ventricular rate being more. So next will, yeah. So this is what is the normal conduction pathway that we have discussed. Now what happens is that, so whenever we are talking about this conduction, and I have said this electrode, the current moving towards the electrode is a positive and away from the electrode is negative. But more precise, I will tell you more precisely how this is happening. So in the heart, what we will learn is that the depolarization wave, which is called as a positive current, I take depolarization, which is nothing but the depolarization, which is nothing but the wave which is contracting the atrium or the ventricles. So depolarization wave moves in a direction called from endocardium to pericardium. endo to peri endo to peri. Okay, so endocardium to pericardium. So now what happens is that Now what happens is that repolarization wave will move in the opposite direction, obviously. Repolarization wave will move in the opposite direction. Let me show you that also. So this is my repolarization wave and this is my depolarization wave. So according to your basic or your whatever source you have learned, so the depolarization wave should always be positive and the repolarization wave should always be negative, because whenever we will look into a heart after placing the ECG electrodes, we will have a positive electrode this side and we will have a negative electrode this side and a positive electrode again this way. So the current which is moving is always moving towards a positive electrode. Now my point is that whenever we have this depolarization moving from endocardium to pericardium and it is moving towards the positive electrode, the positive current, the depolarization current is called as a positive current. The positive current is moving towards positive. Then definitely we get a positive deflection on the ECG. In the same way, the negative current, which is moving away from the positive, the negative current is moving the negative current is moving away from the positive electrode, which is again a positive. See, this can be correlated with the same policy in life. Whenever a positive thing in our life moves towards us, if we are positive, and if a positive thing is moving towards, we always be benefited. Even in the same way, if a negative thing is moving away from us, then definitely we will be benefited. But if a negative thing is moving towards negative, then definitely we will get negative deflection again. That means if the negative current is moving towards the negative current, we get a negative deflection. Even if the negative current, that is repolarization current, is moving towards the positive electrode, we get a negative deflection, right? Again, I'm repeating here, there is no confusion. The depolarization wave will move from endocardium to pericardium as it is moving towards the positive electrode, and depolarization wave is a positive current. It is moving towards the positive electrode. That's why the deflection on the ECG is positive. Repolarization current is considered negative current. So the negative is moving away from the positive electrode, which is also a positive deflection on the ECG. But if the negative current, that is repolarization current, moves towards the positive electrode, we get a negative deflection. That is the reason we get a P wave, a positive wave, QRS, a positive wave, again T wave, which is a repolarization wave and a negative current, but a positive wave because of this logic. That's the concept here with regards to the conduction. So next we'll be moving on to that's the conduction mechanism and the basics and the concepts behind the conducting system and the conduction pathways in the heart. So now I will tell you the lead placement of the heart. So I have just given a gist here. So we'll have a right arm, we have a left arm. So right arm will have a negative electrode placed and the negative current. So the negative electrode will push the current towards the left arm, which is having a positive electrode here, so which is the first lead. Then we have right arm and an electrode towards left leg, which is a lead 2 again, which is having a positive electrode here, and the left arm sending current to left leg, which will be this. So this is nothing but the limb leads. The thing I'm talking about, 1, 2, 3 is limb leads. For the next 15 minutes, we'll be talking about lead placement and the leads, how this lead system works. So these will be the limb leads. And we also have three other leads, AVF, AVR, AVL. How is this leads coming? So you might ask, there is right arm placement of a lead, then we have a left arm placement of a lead, we have left leg placement of lead, then what happened to right leg? Right leg is a neutral. We need to have a neutral. That's how current in your house also works. So we need to have a neutral, otherwise complete phasing will be gone. So now what happens? We'll be talking about the AVF, AVR, and AVL. So AVL is nothing but a left, L for left. So what happens? I need this sided lead, that is left arm sided lead, and I will be neutralizing the right arm and the left leg, and I will get the limb lead AVL. In the same way, if I wanted AVR, I will disable the left arm and left leg current leads, and I'll make this right arm active, and this will be AVR. And if I wanted AVF, then I'll make both right arms and left arm disabled, and I will be having AVF, the foot lead, as the next limb lead. So these will be the 6 limb leads, that is AVL, AVR, AVF, and 1, 2, 3. Then you can clearly see in the previous slide, I have said that the heart placement is this way. If you could clearly see, the positive electrode that I talked is this one, okay, and this one, and the current is moving this way. Just a small recap, and we'll be talking about the chest leads now. Let's draw the heart again. Right, we have a heart. Sorry, heart has become fat. Right, so I have a septum. Yes. So I'll be showing you the chest leads right now. So the chest leads are, we know, V1, V2, V3, V4, V5, and V6 will be our chest leads, and the placement of these chest leads will be V1, V2, V3, V4, V5, and V6. This is how we will be placing the chest leads. And now, what is this chest leads actually representing? So V1 and V2 will be the septal leads. That means which is looking at the intraventricular septum, ventricular septum. The same way, V3 and V4 are anterior leads, which is looking at the anterior chest wall, anterior part of the heart. So anterior heart is nothing but mostly occupied by left ventricle, and we have V5 and V6, which are lateral leads, which are looking onto the lateral side of the heart. Right? So now, if you have understood this, I will show you the placement of all the leads and what are all the leads looking into which side of the heart. So this is how the complete lead placement, whenever an ECG leads are placed on your body. So which leads are looking into which side of the heart is my question. So I would say, as I said, V1, V2 will be the septal leads, and that's it. No limb lead is looking at them. V3, V4 is the anterior leads, and that's it. And we have V5 and V6, which are called as lateral leads. Even the limb leads, one AVL is also looking at the lateral part of the heart. Okay, then we have two, three AVF. These two, three AVF leads are looking into the inferior part of the heart. Inferior heart leads. 2, 3 AVF, and AVR obviously is on the right side. Then definitely it is looking onto the right side of the heart. Cool. So the lead placement is over. With this lead placement, we will take the same thing into the axis. So the next important thing, whenever an ECG is given, we have to know the axis. So when we have given an ECG by our professor or our PG, and we were asked to look into the ECG, and first point we'll be looking into the rate, then we'll see whether it is a regular rhythm or not. Then we have to know the axis of the heart. Look into this very carefully, because many of you have a confusion in this particular area with the axis. So one AVF, 2, 3 AVL, AVR. Normally we study as -30 to +90 degrees is called as normal axis. We study, right? But my question is again, why only -30 to +90 is called as normal axis? Why is it not +90 to 120 or +90 to 180 or +90 to 270 or 100 to 200? Why not? Again, the question why arises here. Before that, I will tell you why. Before that, this is -30 and this is +90. And yes, this is the normal axis of the heart. So this is the normal axis of the heart. As we have already discussed that the current is moving towards the positive electrode and it is moving from endocardium to pericardium, and in this direction, that's why we take it as the normal axis is between -30 to +90. That's the reason. So here the leads which are present in the normal axis are AVL 1 to AVF. So in the normal axis, the leads, in the normal axis leads, all the waves will, I mean, the waves will be positive. We'll have positive waves. The leads which are present outside the axis, that is nothing but number 3 and AVR, will have negative deviation or negative waves on the ECG strip. So I will simply say, if leads AVL 1, 2, AVF are having negative wave, can we say axis deviation? Yes, you can say axis deviation. If lead 3 and AVR are having positive waves, can we say there is an axis deviation? Yes, I can say axis deviation. But the point here is, what type of axis deviation? Is it left axis deviation, or is it right axis deviation, or is it extreme axis deviation? Which axis deviation is the question? So that's where you have to learn the method of axis calculation. I will say it very easily, and it is by taking R minus S. R minus S, yes. R minus S in 1 and AVF. Wait. You might be thinking, what is this R minus N 1 and AVF? In leads 1 and AVF, again I'll have a sample. In the leads 1 and AVF, 1 and AVF, R minus S, the number of small boxes R wave has progressed to 1, 2, 3, 4, 5, 6, 7. 7. Number of small boxes, a small S wave has progressed to 2. So here R minus S is 7 minus 2 will be plus 5. In the AVF, the R wave is somewhere around 3 plus 4, again 3 plus 3, 6, and S wave, there is no S wave, and it's plus 6. Right? Yeah, as you said, I have calculated R minus S in lead 1, R minus S in AVF, and I got plus 5 and plus 6. Now what? Now how I can say the axis of the heart. Okay. Take the x-axis and the y-axis generally, okay? And nothing but, as we have seen here, the axis of the heart, we have 1 and AVF. And you might ask me, sir, why did you only take 1 and AVF and why not others? You can take others, but take only two leads which are present at 90 degrees to each other. So here 1 and AVF is 90 degrees to each other, and we have 2 and 3 also as 90 degrees to each other, and we almost have AVL and 2 also. We can take any of these leads and you calculate R minus S and you will get the axis. I will tell how. Now I have got 5 plus 5 here, so you can mark plus 5 on x-axis here, and we have got plus 6. Yes, plus 6 here, and the meeting point is this. So whenever you take the meeting point, it's minus 30, and minus 30 degrees is what? Normal axis, within the normal axis. In the same way, I will explain it again, the axis part. So you have to calculate the R minus S in any of the two perpendicular leads. And if you take the perpendicular leads as 1 and AVF, calculate the total number of small boxes R wave has progressed in lead 1 and S wave has progressed in the lead 1. Then R minus S, that is 7 boxes here and 2 boxes here. 7 minus 2 will get 5. In the same way, do the same thing for the AVF and you calculate the same R minus S and you get 6 minus 0, you got plus 6. To make it much more easier, you take as x-axis and y-axis and mark the plus 5 on x and plus 6 on y, like you do in your kindergarten. So sorry, in you you do in your 10th class graphs. So then you have to point the common point here, and the common point should be within the normal axis only. So this common point can fall here, because all these common points are within the axis, that is minus 32 plus 90. So the ECG which we have seen is having a normal axis. What if it has fallen somewhere here? The point we have calculated has fallen somewhere here, and it is outside minus 30 but towards left side, so we say left axis deviation. So if the point is fallen here, somewhere here, so it is outside the axis again but towards the right side, so we say right axis deviation. So if the point has fallen here and it is outside the axis but extremely right side, we say extreme right axis deviation. So just with this axis deviations, we can clearly say what is the use of this axis. Okay, I told you what is normal axis, why it is called as normal axis. Then I have told you how you can calculate the normal axis. Then I have told you what is left axis, what is right axis, what is extremely right axis. But what is the use of this axis? So with the help of axis, we can know the direction of the current that is moving in the heart. So if the heart muscle is more on the right side, the more power or more amount of current will move towards the right, and we get a right axis that's called right ventricular hypertrophy. In right ventricular hypertrophy, we can clearly see right axis. Even in the same way, whenever there is a left ventricular hypertrophy, we can see a left axis deviation. So likewise, this axis is very useful. So this is how you actually have to calculate the axis, and I think you have understood this. So let us move forward with the next concept, leads and its blood supply. What? Leads and its blood supply? Yes, leads are also are also having a blood supply. It's nothing but whatever the heart is having as a blood supply, the leads will also have. Yeah, but which arteries are supplying which leads is the question again. So generally we have right coronary artery, which is supplying to SA node, which is supplying to AV node, right atrium, right ventricle, and posterior one third of interventricular septum. And we have a left anterior descending artery, which is a branch of left coronary artery that is supplying to the anterior part of the heart, or I can say the left ventricle. And the same LAD also supplies to anterior two thirds of interventricular septum. And we have LCX. LCX will be supplying to, that is left circumflex artery, which is also supplying to the lateral part of the heart, right? Lateral part of the heart, and sometimes it will also contribute for the anterior two thirds of IV's interventricular septum. And there is one very, very important point I want to say is a posterior descending artery, which can be a branch of either RCA or LCX. If it is coming from LCX, we can say it is left dominant. If it is coming from RCA, we can say it is a right dominant artery, and this posterior descending artery is supplying the inferior most part of the heart. So we have already discussed that which side of the heart is taken by which leads. So first thing, the anterior side of the heart. So anterior side of the heart is taken by V1, V2, the septum is also anteriorly present. So V3, V4 is present. So V1, V2, V3, V4 is supplied by LAD, that is left anterior descending artery. And what happens with this left anterior descending artery? If there is a block in the left anterior descending artery, anterior part of the heart will be gone, and that we call it as anterior wall MI, right? Then we have the lateral part of the heart. So whenever there is a lateral part of the heart, and we have discussed that V5, V6, lead 1, AVL is also seeing the lateral part of the heart, and this lateral part is being supplied by the left circumflex, so lateral circumflex, the left circumflex artery. So whenever there is a block in this left circumflex or the lateral circumflex, this will be having a left lateral wall MI. Very clear. Then what is the inferior part? Who is looking at the inferior part? Which leads are looking? 2, 3, AVF. So these 2, 3 AVF are looking at the inferior part of the heart, and who is being supplied by both RCA and also posterior descending artery. And whenever there is a block in the RCA and in the posterior descending artery, we will be having the classical inferior wall EMI. Very clear. There is a block in the respective arteries, and there is a respective lead changes we can clearly see, and we can diagnose MI. That is very clear. And here, one more interesting point I would like to add is that, so as we have discussed that RCA is supplying both SA node and also AV node. So whenever there is a block in this RCA, whenever there is block in this RCA, definitely SA node will be inhibited and AV node will be inhibited. That's why whenever a patient who is having inferior wall MI comes, the patient presents with bradycardia because SA node is not functioning properly, AV node is not functioning properly due to lack of blood supply, and due to bradycardia, the patient goes into hypotension, right? Due to the patient goes into hypotension and he collapses, and that's what we called as inferior wall MI patients having cardiac arrest. So most of the times, these inferior wall MI patients will not have a time to call for help because they immediately go into hypotension and they collapse. And that's the very reason you have to treat inferior wall MI as soon as possible before SA node and AV node lacks blood supply. Even in the same way, whenever the LAD that is being blocked and anti-reval MI is developed, immediately sympathetic nervous system will be activated. And whenever the sympathetic nervous system is activated, heart rate increases, BP increases in the patient, and which is actually a compensatory mechanism. And the patient will be in the tachy with changes in the respective leads, and patient will be having hypertension comparatively, and we can clearly diagnose it as anterior MI, and you have to treat it accordingly. So this is also a concept behind this RCS applied to the lead to the nodes, and also the respective changes in the leads and the clinical presentation to you when they come. And that's how you can immediately react to a patient with MI and treat accordingly. So let's move forward. So which lead have looked into which side of the heart, and which lead has been supplied by the arteries of the heart is also discussed. So the next important lead we'll be talking about is the waves. The waves. So this is interesting because we'll be studying a lot of basics, how this P wave is coming up, how this QR is forming, how the T wave is coming. So far, we have discussed the basics, and we have also discussed about the leads. I think many of you have clearly understood. So next, we'll be moving on to uh, the waves. So the firstly, let me draw a normal ECG. Yes, this is a P wave, Q, R, S, and we have a T waves. So this is a normal ECG wave, normal ECG. And the first I'll be talking about is P wave. So I'll ask a question. What does this P wave represent? So the representation of P wave is nothing but atrial depolarization. As I said, depolarization, and it is nothing but a positive current. We have a positive deflection here. Depolarization, sorry, depolarization, atrial depolarization. Very good. But how we know this P wave is emerging is the question. So I will draw another wave which you might be familiar with. Yes, this is very important. This is nothing but the SA nodal action potential. And we also have, I'll be syncing this with P wave, the emergence of P wave. Yes, this is my P wave. So I have written 403 on this particular SA nodal action potential. So what does that mean? It is nothing but phase 4. 4 is nothing but phase 4, which is a slow sodium depolarization. Slow sodium channel depolarizing waves. Okay, and then we have zero phase 0, which is a again sodium, but sorry, which is a calcium. So it is a rapid conduction or rapid depolarization. Then we have 3, which is nothing but potassium. Phase 3, potassium moving out, we have a repolarization of atrium. Repolarization of the atrium. We'll talk about this again. But firstly, let me sync this exact wave with the action potential. So this is what, see, the upright wave which we have is atrial depolarization, and that atrial depolarization is nothing but phase 4 slow depolarization or due to sodium channels, and phase 0 calcium rapid conduction or rapid depolarization. So this P wave which we have seen right now is nothing but atrial depolarization. But the question is, we have two atrium, right? This P wave represents to what? Right atrium or left atrium? Tell me, how many of you know this? The P wave which we see on the ECG, is it representing right atrium or left atrium? Just give me the comments. I'll wait for a minute. I just want this to be interactive. So just tell me, how many of you know the P wave which we see on the ECG, is it representing the right atrium or left atrium? Come on, this is interesting. Come on, guys. Right. Someone said both, and some are saying left, some are saying right. Majority of them are saying right, and the answer is both. Yes. So listen to it very carefully. The P wave which we are seeing here, 70% of the P wave belongs to right atrium, and only 30% of the P wave belongs to left atrium. Right. So this is very much clearly visible on lead 1, 2, or V3, V4, which are anterior leads, which is upright wave. So whenever there is a problem with this wave, for example, if you look into a normal ECG in lead V1, you will see the same P wave in different manner. This way. Just take a normal ECG. I have placed a normal ECG in the PDF. Just look into lead V1 and you will clearly see a S-shaped hook-like wave, which is completely called as a P wave. So here the upper part is right atrium, upper part of the P wave belongs to right atrium, and the lower part belongs to left atrium. So right atrial contraction will be represented by this upper part, and left atrial contraction will be represented by this lower part. So whenever there is a change in the P wave morphology, they are related to any clinical condition, then definitely we can look into lead V1 and we can define whether there is a problem with the right atrium and the right ventricle, or left atrium and the left ventricle. Right. So I will show you two waves and we will see the abnormality that we have found with the wave. This is my P wave. So now what happened is that the left, as I said, majority 70% of the 70% of the P wave is consumed by right atrium, and only small 30% which is close to the this P wave is belonging to the left atrium. But what happened here is that the left atrium part has come out. So this is right atrium and this is left atrium. Generally, what happened? The right atrium 70% has been normal only, but the left atrial part has become more. This clearly indicates there is a pressure increase in the left atrium. Increased pressure in the left atrium. So, what was one condition that you can remember? What is one most common and very important condition that you can remember, where there will be massive increase in the pressure in the left atrium and there will be this kind of wave in lead 2? That is nothing but mitral stenosis. In mitral stenosis, in mitral stenosis, whenever there is a very narrow orifice, the blood flow from left atrium to left ventricle will be very difficultly moving, and this resulted in increase in lot of pressure in the left atrium. This resulted in getting a wave due to increased pressure, a wave that is separating from the right atrium part of the P wave, and we get a broad P wave, and which is looking like an M. And it is due to mitral stenosis. We call it as, this kind of abnormal P wave is called as P mitral. Beautiful, right? Then we have another kind of wave I'll be drawing right. So we have this kind of P wave. This is my P wave, which is very much taller than my normal P wave, which I could look in the lead 2, which is my standard lead. Right. So this is very tall. Now what happened is that, as I said, the majority is occupied by the right atrium and 30% is from the left atrium. The left atrial part is normal, that only 30%, but the right atrial part has become so large and very tall. Something is going on in the right atrium. Very clear. This is nothing but increase in the right atrial pressures. So there can be a lot of conditions where there might be an increase in the right atrial pressure, but one common condition where we can clearly see there is a massive increase in the right atrial pressure is cor pulmonale. Yes, what happens is that in cor pulmonale, due to increase in the pulmonary pressure, there will be increased pressure in the right ventricle. So this right ventricular pressure will be moving on to the right atrium, and the right atrial pressure will result in large amounts of P waves. So this large P wave, which we can see in cor pulmonale, is called as P pulmonale. So why did I tell this here is that just by looking into P wave, we can literally diagnose mitral stenosis and also cor pulmonale. And if you see in lead 1, and if it is P pulmonale, the right atrial P wave will be this way. And if you could, in V1, if you could see the P mitral, you can see large downward P wave. So we can clearly say P mitral. This is very simple method of looking into P, and the disease we can identify through ECG, right? So as we have discussed, the SA nodal action potential, which is being dependent on sodium, calcium, and also potassium. So whenever there are abnormalities in the abnormalities in the sodium and calcium and potassium levels in the body, then definitely there will be a change in the P wave. That means if there is a, for example, if there is hypocalcemia, the P wave will be, what will happen to the P wave? Obviously, the P wave will be slowly coming, or the P wave will be smaller. Whenever there is hypercalcemia, the P waves will be coming faster and P waves will be bit taller. The same way that applies to the hyponatremia, hypernatremia, even for the hyperkalemia and hypokalemia. I will come to that hypokalemia, atrial repolarization wave, that is T wave changes. But next we'll be moving on to the wave QRS. Yes, this is my QRS. So what does this QRS represent? Yes, obviously ventricular repolarization. So even this QRS wave has a representation of AV nodal or ventricular action potential. I will draw that as well, which will make it very easier to study the electrolyte abnormalities and the ECG changes. That's why I have clubbed both of the concepts and explaining you. So here we have the ventricular action potential. The resting one is potassium, and this is the sodium upright one. And we have inward K plus rectifiers. Then we have calcium channels. Then we have potassium channels again here. So this exact synchronized with the QRS. Let me draw the QRS and its synchronization. Exactly. So this is the exact synchronization of the ventricular action potential and the respective electrolyte channels and the ventricular repolarization and atrial repolarization as well. So this is very clear that sodium and calcium are responsible for this ventricular depolarization, and potassium is responsible for the T wave, which is called as atrial repolarization, and the PR segment which we have here is also responsible for the potassium, and which is an isoelectric segment. Even potassium, that's what we have discussed. Potassium is the main electrolyte that is responsible for these changes in the ECG. So, with this action potential, what if there is a hypernatremia? What if there is a hypernatremia, that is increased sodium content in the body, or hypercalcemia? Then definitely we can say we will be getting narrow cures. Yes, we can say that. If there is a hyponatremia, right, or hypocalcemia, we can clearly say we will be getting broad cures, obviously. So whenever there is hyperkalemia, we will be getting tall T waves, right? Whenever you are having hypokalemia, you'll be getting flat T wave or inverted T waves. So, very important point here about these T waves, because many of you get confused about the T wave which we see in MI and the upright tall T wave which we see in the MI patients, and also hyperkalemia kind of T wave. So, in the just the basic differentiation you could find it is that in a hyperkalemia patient, the T wave should be more than two and a half large boxes. More than two and a half large boxes, or at least two large boxes, then we can say it is due to major electrolyte imbalance, hyperkalemia in the body. Otherwise, if it is less than two boxes and it is tall, then definitely it is EMI. MI patients will also have taller T waves. We will discuss that later, but this is what you have to remember. Even whenever there's hypokalemia, and we'll have flat T waves, inverted T waves, and we also have a U wave coming. And what is this U wave, which we have to discuss next? U wave is very simple, nothing but T wave is atrial repolarization. U wave is also repolarization wave, but from the Purkinje fibers. Repolarization due to Purkinje fibers from the Purkinje fibers. So that's what the concept. So electrolyte imbalance is also over here. So we have to synchronize this way with the ventricular action potential and the ECG occurrence. So it will be very easy when you look into an ECG without panicking. So this is one part. Let's move into the next important thing about the waves. So again, I'll say. So I will draw QRS. So this is my QRS. Again, my question, as previously asked, the P wave which you see on the ECG, as you said, the right atrium and left atrium. What about the QRS we see? Is it the right ventricle or the left ventricle? Come on. Next question. Is it the right ventricle or the left ventricle? Just put in the comments. I'll be waiting 1 minute. Yes, the PDF is available in the description of this video. Please download the PDF. You can clearly understand everything. So give me the answer. The QRS which you see on the ECG, is it right ventricular depolarization wave or is it left ventricular depolarization wave? Okay, left ventricle, right ventricle, left ventricle, right ventricle, left ventricle, right ventricle. Come on, give me a proper answer. Yeah. So the answer is both, right? The answer is both, but how is my question. So V1 and let's take V6. So here we can clearly see in V1 we have a R and we have an S. And V6, you take the normal ECG that I have given on my PDF, then you can clearly see. And we have in a V6, we have a Q and we have an R. Right? In the V1, the small r which you are seeing is representing the right ventricle. The S which you are seeing is representing the left ventricle. In the same way, the Q you are seeing here representing the right ventricle, and the R you are seeing is nothing but the left ventricle. Very simple. But why did you say which whatever? Whichever is representing which, the entire QRS is representing ventricular depolarization, but what is the use? There is a use here because we can clearly see the right ventricular right ventricular hypertrophy. If there is a right ventricular hypertrophy, we can clearly see in V1 there will be tall R wave when compared to the S, and deep Q wave when compared to the R in the V6. Even if we have a left ventricular hypertrophy and V1, we can clearly see the more taller S wave than the R, and in V6 we can clearly see the taller R R wave as we can clearly see. So this is what the use of we looking into V1 and V6 with regards to know whether there is a left ventricular or right ventricular hypertrophy, which will be very, very useful if a patient with hypertension comes to you, and if you want to know whether there is a changes have occurred due to no the primary hypertension or due to increase in the pressures in the peripheral vasculature leading to the changes in the heart, we can look into these two leads, V1 and V6. We can see that the patient is having hypertension and he's not on any medication and his heart is being affected, and we should act as soon as possible. So this is what the use we have to look into, right? So I will tell you how you can know there is right, or I mean like ventricular hypertrophy. So in V1, yes, part of the V1 plus R part of the V6 should be more than 35 mm, more than 35 mm if you mix both 35 mm, 35 small boxes, we can say the same way. So this will be the ventricular hypertrophy, that is left ventricular hypertrophy. This is how you can know there is a left ventricular hypertrophy in the patient. So next, the very interesting part has come. So we have completed all the basics of the ECG, about all the leads part, about all the waves part, about the axis, about the direction of the current. Now we'll be moving to the disease per se. So we'll be moving on to the disease of the ECG, the disease of the heart, which we can see through with ECG. Right. I hope every one of you have understood the basics well, because whatever we'll be discussing next will be the diseases only, which will be very, very quicker and faster. I'll be talking it faster. Yeah, I'll be explaining the basics and all. I will definitely explain the concepts as well, but not the decoding the basics and explaining the disease part. So if you have understood the basics, just give me a thumbs up and I'll be moving on to the disease part. And I have the modules ready. Yes. So before we can go into the diseases, and the first thing I wanted to say is that you can interpret the ECG by just four points. Yes, 4 points. Whenever an ECG is given, you just have to take the ECG, look into the heart rate. Second point you have to see is whether the rhythm is regular or not. The third point is what about the P wave and the PR interval? Is it normal or not? And the fourth point is that the morphology, just the morphology of QRS, and with these 4 points, you can clearly interpret ECG just 30 seconds. In just 30 seconds, you can clearly interpret, but that comes only if you practice it more and more. So let's move forward and see what happens is that we have an ECG here. I said 4 points. What is the 4 points? First, I have to calculate the rate. Second, I have to look into the rhythm. Third, I have to look into the P wave and the PR interval. And fourth, we have to look into the QRS morphology, right? So firstly, I'm taking our ECG where I wanted to calculate the heart rate. So three boxes are present between two RRs. So we'll be having 300 by 3 is equal to 100. So the point here is normal heart rate is between 60 to 90 and tachycardia will be more than 90 and bradycardia will be less than 60 per minute of the heart rate. So what happens here is that the patient had 100, then definitely yes, tachycardia. I agree to the point as I have said, right? Then next point is rhythm. So every RR interval has 3 3 3 3 boxes in between. So it is a regular rhythm. So next point, I told you to look into P wave. Why did I ask you to look into P wave? Because if there is a P wave and the morphology of the P wave is normal and the PR interval is also normal, then we can say there is a normal functioning SA node and there is a normal conduction of current from SA node to AV node. That's why I asked you to look into P wave and the PR interval. And one blinder that you need to remember is that no matter what, in a normal ECG, the P and the PR interval, P and PR interval should be occupying only half of the large box. Remember very clearly, only half of the large box, the P and the PR interval should occupy. Do not remember whether it should be point or not 2 seconds or 0.102 seconds. That doesn't matter. The P and the PR interval should occupy only half of the large box. If it is occupying only half of the large box, then it is said to be normal SNodal function. So let me see here. The P wave and the PR interval is occupying only half of the large box, and the morphology is also normal in my leads here. So we can clearly say the P wave is present, SA node function is normal, PR interval is normal, conduction is also normal, and QRS complexes looks fairly normal without any narrowing or without any broadening of the QRS. And this ECG is nothing but a sinus tachycardia ECG. Yes, there is axis problem here. I don't want to mention. I just wanted to let you know how a sinus tachycardia ECG looks like. Right? This is a sinus tachycardia ECG. Next, let us move on to the another ECG. So let me calculate the heart rate again. The first point I want heart rate. Again, 4 points we'll be looking into heart rate, rhythm, and P wave and QRS. So the heart rate here will be 1, 2, 3, 4, 5, 6, 6.5. 1, 2, 3, 4, 5, 6, 6, 6, 6.5. Somewhere 300 by 6.5 will be somewhere around 56 somewhere. Okay, 56 is my heart rate here. 56 per minute, maybe much more lesser, 6.5. So much more lesser, maybe 45 or something like that. So yeah, so 45, as we have said, less than 60 will be what? Bradycardia. I have found bradycardia. Then I want a P wave and PR interval. The P wave and PR interval are present and they are normal and they are occupying only half of the large box, half of the large box, half of the large box, and I can clearly say the P wave is present and normal, PR interval is normal, and QRS is nothing less than normal, and no broadening or no shortening, and QRS is also normal. From this, we can clearly say the problem is sinus bradycardia. There is normal functioning, but they are conducting at a normal pace. Right. Let's move on to the next ECG. Yeah. So yeah, this is quite looking quite typical. What happened? Let's calculate the heart rate. Nothing to panic. Our four basic points. Let me see. First point, heart rate. I want to calculate heart rate. So here, what happened? I have two boxes, three and a half box. Again, two boxes, two and a half box, two and a half box, two boxes, two boxes. Oh my God, there will be seven boxes. So two, two, three, two, two, two and a half, again seven boxes. This clearly shows that the rhythm is irregular. The rhythm is irregular, and definitely we have to calculate by third method, that is calculate the number of hours and multiply with 6. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and 12 into 6 is nothing but 72. My heart rate for this, maybe this is some part of the ECG is missing, or this is a complete ECG. So 72 will be my heart rate, and irregular rhythm is what I have found. And nothing to panic, we'll come to the diagnosis. But before that, we can clearly see at some leads we are having a tachycardia, right? And some leads we are clearly seeing a bradycardia. What is the third point that we have to look into an ECG when we have to interpret it is the P wave. You see the P wave and the PR. There is no PR at some areas. There is no. I mean, like the PR segment itself is not there. We can clearly see here. See, look into the P. Look into the P. It is getting on top of getting on overlapping with the QRS, and we have a P here. There is no PR. So the SA node is functioning rapidly before it could sense an isoelectric segment, that is PR segment. And see the lead here, we have a PR interval being prolonged, and we have a PR interval being broader and prolonged, and which is occupying more than half of a large box, and which is clearly showing there is a dysfunction in an SA node. Dysfunction in my SA node. SA nodal dysfunction can be seen because we can. So SA-nodal dysfunction can be clearly seen, and this SA-nodal dysfunction clearly indicates a tachycardia at some places and bradycardia at some places, and our diagnosis will be sick sinus syndrome. That's nothing but tachycardia bradycardia syndrome. This is how the tachycardia bradycardia syndrome ECG looks like. I am erasing everything. You can look into my PDF and it will be easier for you to understand. There is a tachycardia at some places with the change in the P wave, and bradycardia at some places with the change in the PR, which clearly indicates there is a dysfunction in the SA node. It is functioning properly at some, it is over functioning properly at some places, and it is least functioning at some places, which clearly shows this is a case of tachycardia bradycardia syndrome. Let's move on to the next ECG. And what we can see first, whatever it is, you whenever you look into an ECG, you find an abnormality, right? Why not atrial fibrillation? We have a P wave, man. Why it will be atrial fibrillation? Come on, let's not make silly mistakes now. And yeah, so whenever we have an ECG and we see an abnormality clearly, but our basics are the 4 points. What is the heart rate of this ECG that I have given? I wanted the heart rate. Let me calculate it. Can I say before I calculate heart rate, I have to know the rhythm. Is it regular rhythm? uh, 1 2 3 4 and half here, and some part four and a half. 1 2 3 4 5 here. So four and a half, four and a half, 5. 1 2 3 4 5 here. 1 2 3 4 5 here. Yeah, almost it's a regular rhythm, right? It's a regular rhythm, right? So if it is a regular rhythm, then we can easily calculate by 300 by 5, which is nothing but 60 per minute. My heart rate is for this ECG is 60 per minute. And what next? We have to look into the P wave. Can we see the P wave and the PR interval? Yes, we can see the P wave and PR interval quite normal. It is looking quite normal at places, quite abnormal at places. Okay. No, it's not normal. It's abnormal clearly. We can clearly see it is occupying more than one box. It is occupying one box here. It is occupying almost three-fourth of a box. So P wave and PR interval slight, or we can say mild prolongation has been there. So SA nodal dysfunction is there in this patient, mild SA nodal dysfunction is there. Then we have to know the QRS. How is the QRS? The QRS changes in the QRS, and also there is a change in the ST segment clearly. The point has come. A change in the QRS, a change in the ST segment as well. So here, what are those changes? So we can clearly see ST elevation. Previously, we have discussed if there is a changes in the QRS and ST T changes in which of the leads, then corresponding to which of the artery and which part of the heart. So here the changes are clearly seen in 2, 3, and AVF, and it clearly shows those three indicates the inferior part of the heart. So inferior part of the heart. So I can say this is an ECG of inferior wall MI, and the points we have learned is that inferior wall MI, the patient will be having a bradycardia, the heart rate is 60, almost bradycardia. The patient will be having, hypotension, and this bradycardia can also be justified by P wave and PR changes, that SA node is not having proper blood supply, and all the points that we have studied are present in this ECG, and we can clearly say it is an inferior wall MI. This is a ST elevation MI. So before we could move on and discuss about this other ECGs, so one thing I would like to ask you everyone, yeah, we say ST elevation is MI. In if it is in inferior leads, if it is inferior wall MI, if it is in the anterior leads, it is anti-wall MI. But what is the reason for ST elevation? Why there is ST elevation? Why is my question. Medicine is why. So the answer will be here for you. So whenever there is an ST elevation, so this is my ventricular myocardium. So we have a transmural or a complete damage of the ventricular myocardium right from the endocardium to pericardium. This complete damage will result in this complete damage of this ventricular myocardium due to MI will result in current moving above. So when the depolarization wave which is moving from the endocardium to pericardium in the normal one is moving the same way, but here due to the damage which is present in the myocardium, the current will try very much to pass through, but it finds very difficult to get through it. That is why there is a prominent elevation of the, it is trying to find a way to get through the damaged myocardium, but it can't. So we clearly have a elevation ST elevation. But the next question is, can we see ST elevation as soon as the patient is having an MI? No. There are different kinds of ST elevation MIs, right? Or the changes we see in an MI patient, be it an anterior wall MI or inferior wall MI or lateral wall MI, and if it is an ST elevation MI, we have different kinds. The first one is a hyperacute MI. What is this hyperacute MI, and what is the concept behind hyperacute MI? In a hyperacute MI, the patient, whenever the patient will be having an ongoing severe chest pain, and the patient will be having broad and tall T waves. Remember, This broad and tall T wave will be staying only for very few minutes, very few minutes. The change we can clearly see only for very few minutes. But what is the reason for this tall T waves that is coming for just few minutes, which we considered in hyperacute MI is that? So there is a basic physiology we can understand here. So whenever there is ventricular myocardium damage is there, the cardiac myocyte which is present will also be damaged, right? There is no blood supply and there is disruption of the cardiac myocyte. This disruption of the cardiac myocyte, any cell disruption, what happens, which electrolyte will be moving out? K plus is the electrolyte which is moving out. So due to large amount of cardiac myocytes or the cardiac muscle fibers being damaged and the K plus being accumulated there, K plus being accumulated there, the ECG electrode will think it as a hyperkalemic, but not as much as we see in a blood. So that's the reason the patient will be having a broad plus tall T wave. Very few minutes. As the as the infarction progresses, we will be having acute STEMI. That is nothing but the T wave, which we have seen as a broad and tall T wave, will be taking the ST along with it, or we can also see the same acute MI this way. This is my ST segment, this is my ST segment, and this is my T wave. So the patient will be having a broad, tall T wave along with an ST elevation. We can clearly say it can be an hyperacute MI or acute MI. The next type of MI will be subacute MI, subacute ST elevation MI. Now the patient will be having an MI of this kind. There is a T wave inversions. Yes, this ST segment will be present for at least minutes to hours. This T wave will be present from minutes, hours, even for days. Minutes, hours, and even for days. So subacute MI or acute MI. So whenever a patient is having a severe chest pain, acute chest pain, and patient is having a T wave inversion, and we can consider this as one of the prominent ECG change for an evolving type of MI. Either it is an inferior wall MI or anterior MI. So then we have a chronic or an old STEMI. What happens? The patient will be having this way. This is how the patient's ECG wave will look, and we can clearly see this is called as Q wave, and this is T inversion, and presence of this Q wave, which I have written as a small q, is nothing but a pathological Q wave. Pathological Q wave. So this pathological Q wave is nothing but evolved or old MI, right? As clear as that. So whenever a patient comes, and we can clearly see the patient initially presents with a hyperacute MI, progresses to acute MI, progresses to subacute, then chronic, and this hyperacute to subacute, we can clearly say within 4 to 6 hours the ECG changes. So that's why we order, whenever a MI patient comes, we order ECG for every 2 hours or every hourly ECG in order to know uh, whether the MI is progressing or not, because the progression of MI will clearly indicate that the damage is being more severe and it is transmural. This is what the points we can learn from just ECG, what's happening at the organ level. That's the beauty here that we can see. Right. Then the next clinical point is that, okay, a patient has come and patient is having severe chest pain, and we are looking at the ECG and I find nothing. The ECG just calmly looked like this. Now what I have to do? That's when we have to go with the diagnosis N STEMI, right? Yes. Can we N STEMI, and another differential diagnosis is unstable angina. In both of them we can't really find the ECG changes, but sometimes and the ECG change in NSTEMI we can clearly see an ST depression. I'll tell you why there is an ST depression, don't worry. There is an ST depression, and sometimes we can find a normal looking ECG but ongoing severe chest pain. That's when the next investigation, that is cardiac biomarkers, we'll see CKMB and troponin levels. So CKMB is only useful up to 4 hours, but TROPI will be useful from 4 to 24 or 48 hours even in some conditions. So TROPI will be more significant. High sensitive TROPI is now being used, which is more specific for the cardiac muscle damage. So if biomarkers are positive, then definitely it is NSTEMI, and if it is negative, we can say it is there's a possibility that the patient is having unstable angina, and we can rule out unstable angina by giving adrenaline shot. And if the patient is having unstable angina, the pain increases. We generally don't perform this in the ear, but if you wanted to rule out under supervision, we have to do this. The patient pain will be increasing, then definitely it's unstable angina. If the pain is not increasing, the patient is normal, right? Now radionuclide scans have also come to in order to know whether the myocardial damage is there. Even the patient is having severe acute chest pain and the radionuclide scans are completely normal, then the patient is not having MI, as clear as that. So we'll be moving on to the next. See, I can clearly show you here the progression that we have discussed in a hyperacute, where we can clearly see a broader and a taller T wave. Then in acute MI, we can clearly see ST elevation and the T wave taking uh, the ST along with it. And we can also see the subacute, where the T wave inversions and development of Q waves as well. And see here the improvement of the ST elevation. Maybe the patient has been treated, or the patient is having a strong collateral blood supply around the damaged ventricular myocardium, collateral blood supply. So, and the next one, we having a Q wave being very much persistent and T wave becoming normal. We can say this is a chronic or evolved MI. Very clear, very clear, very clear. You can differentiate now the MIs, what kind of MI the patient has presented with. You can clearly differentiate, and let us see the same way. Don't just straightly go, there is an elevation. The basics are very important. We have heart rate to calculate here. So what is the heart rate? Somewhere around 1, 2, 3, and 4. And 4, 300 by 475 per minute. And is it regular? 1, 2, 3, 4, 1, 2, 3, 4. Yes, this is the regular rhythm ECG, regular rhythm ECG. And what about the P wave and the PR? P wave and PR normal. They almost look normal. The synodal dysfunction is not there, and there is clearly QRS. When it comes to QRS, in lead V2, V3, V4, we can clearly see a tall, broad T wave, and also ST is being taken along with it. See, ST is taken along with it. See very clearly, we can see a broad and tall T wave and an ST elevation present in the anterior leads V2, V3, V4. We can clearly say this is the anterior wall MI, and the patient is having ST elevation with tall broad T waves. Even in this V2, V3, V4, we have MI, tall T waves with ST elevation. Right. So the patient is in acute stage, or we can also say the patient is in acute state, hyperacute or acute stage. We have to react immediately. We can go for either thrombolysis by giving stat doses first, and this is an antival MI. And let's move and look into another ECG. We can clearly look into the heart rate first. So 1, 2, 3, 4, 1, 2, 3, 4, almost 75 per minute, and it's a regular rhythm ECG. I'm going at uh, some speed now because we have many ECGs to discuss. So I think you're following up with the things with the points I'm telling. Just look into the PDF. It will be very much easier for you. Instead, even though I'm going at a faster speed, um, here what we can see the P wave, any change in the P wave, the P waves and PR interval looks almost normal. So P wave and PR are normal, right? P wave and PRs are completely normal. But what we can see in other leads, what else we can see? I can see an T wave and ST elevation AVL, T wave ST elevation 1. Then if 1 and AVL are my lateral leads, then definitely there should be changes in V5, V6. Yes, V4 change, V6 is there. There is V6 and V5 changes are also there. Then definitely there is a lateral leads having ST elevation and also T wave being tall T waves are also there. So in order to confirm, is there any Q or T wave inversions in the reciprocal leads? We can clearly see the reciprocal leads, the three, and also yes, AVR are having the reciprocal changes. Then definitely we can say this is a lateral wall MI, and the artery that is being blocked is LCX. Right. Let's move to the next ECG that we have to look into. Yeah, the same way, let us look into the heart rate. What is the heart rate? 1, 2, 3, 3.5, 1, 2, 3, 3.5, 1, 2, 3, 3.5. Somewhere around 90 to 95 will be my heart rate, and my rhythm will be regular rhythm. And what about the P wave and also the PR? In my standard lead, the P and PR, P and PR, P and PR, there is a slight disturbance, very slight, but almost normal, or half or three-fourths. So I'll take it as normal, and PR is also normal. And what about the QRS? Yeah, the QRS in my standard lead is normal with ST depression, here, right? So this can be NSTEMI. This can be NSTEMI, but previously I told you how I got ST elevation by telling you there is a transmural damage and the current is trying its way to get out of that damaged part of the ventricle, and it has been elevated. But why there is a depression is my question. Why there is T inversion is my question. So there's a concept here again. Let me explain that. Get a paper. Right. So as I move along, so in an ST elevation MI, the damage is clearly present subendocardially. Why there is damage subendocardially? Why? Because in heart we have discussed that the current is moving from endocardium to pericardium, but I haven't told you the point that the blood supply will move from pericardium to endocardium. That means it is very clear that the last one to get the blood is the subendocardium. Huh? It should be endocardium, no? Why endocardium? Because the ventricles will be having blood, right? The ventricles will be having blood, and that blood can be taken by the endocardial part. So the subendocardial part is the last one to get the blood. So we'll be having subendocardial damage here. Yes. Now what happens to the vector of the ST? So ST, what happens? The ST can actually go through the normal part of the ventricle which is functioning and which is not under ischemia or less blood supply. What happens is that whenever the ST segment wants to come to its normal isoelectric segment, that's when the vector will be in the opposite direction here, and the ST will be representing the leads which are present right above it will be representing as a depressed wave. That's the concept here. Okay. And what about the T wave inversions? The T wave inversions will also have a concept, and that's nothing but whenever there is a T wave inversion, the damage is not transmural but intramyocardial damage is there, right? So whenever there is an intramyocardial damage, the current which is going along can go, right? Can go, but the repolarizations which have to come back will be stopping here. That's the reason we'll be having a inverted or T inversions or a negative T waves. T wave inversion. Right. So this is what the reason for T wave. Then what about the occurrence of Q wave, pathological Q wave? Even that has a concept. So every wave which we see on ECG, which is related to a disease, has a concept. And this is nothing but there is a diffuse ischemia of the ventricle. Okay, the ventricle is under high tension of ischemia, but there is one area which is completely damaged. And here what happens is that there will be an electrical window being created. The current which passes will reflect back. That's the reason we have this pathological Q wave, the negative wave and a pathological wave due to formation of electrical window. This electrical window which is created due to complete damage of the ventricular myocardium, resulting in chronic evolved, which we can see this resulting in pathological QA, which we can see in evolved MI or a chronic old MS. This is the reason we can see ST depression, and that's the reason why we see T wave inversions and pathological QAs also. That's the concept behind it. And let's move to the next ECG. Here, let's see what's the heart rate. 1, 2, 1, 2, 3, and 4. 4, 1, 2, 3, 4, 4, 4.2, 4, almost 4. So the heart rate will be 75 almost, maybe 75 per minute. If you wanted more precisely, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and it's 66 per minute. 1, 2, yes, 66 per minute, and we can say the rhythm is almost regular rhythm. And what about the P wave? Can we talk about the P wave? No, yes, we can talk about the P wave. We have a P wave here, we can have a P wave here, we can have a P wave here, a P wave here, P wave here, which looks almost normal. And you might think the standard lead to, yeah, we have P waves, we have P waves. So P wave and PR interval is almost normal. So P and PR intervals are, so this ECG, I think I haven't placed it in my ECG notes. Just look into it. So will be almost normal. Next is the QRS. There is a QRS and also tall T wave, which can be clearly seen in V2, V3, and V5 also, V5 also, and we can see in the two, we can see in one, we can see in AVL. Oh my God! So if it is V2, V3, V4, V4, V5, V6, all the leads, and we can also see it in 2 and AVL and 1 also. So is it antero, lateral, inferior wall MI? No, that's where there is a catch here. So there is a concavity in the ST segment. There is a concavity in the ST segment. But if you go and look into an ECG, which is, see, there's a convexity in the lateral wall MI ECG, and there is a convexity in the anterior wall MI. There is a convexity, but there is a concavity here. Don't worry, why there is concavity also I'll be talking. I said every change in an ECG will have a concept. So this is one possibility that diagnosis is pericarditis. Okay. For you to remember easily, I will just tell you how you can differentiate between pericarditis and MI, but I'll also explain why it is that way. Right. So if you could see here, there is a concavity and smile emoji. Looking like concavity looks like a smile emoji. But in a normal MI, see the convexity looks like a sad face, right? So he's a happy face we can see here on the ECG, and a sad face we can see. What does it represent? MI patients, when they find it, I mean, like MI patients, either anterior or inferior MI, there is high chance the patient might die. So that's why he's sad. But a pericarditis patient, there is a very low probability of patient being dead. That's why he's happy. Even though there is changes in the ST and T wave changes, it's not MI and it is pericarditis, and the patient is happy because he's not going to die. This is a small things how you can remember it, but the concept behind this is what? So I'm drawing a heart ventricle. So pericarditis is nothing but the inflammation of the pericardium. Okay, just inflammation of the pericardium, not infarction. It's just inflammation. So the current which is coming happily comes up to here, but when it comes to the pericardium, it just tries to bend and move around, and again it becomes normal. I think it's very clear. The pericardium, which is under inflammation, the conduction is just trying to bend and move across and be again normal, which will give you the pericarditis concave wave. So, as it is just an inflammation of the pericardium and not the damage to the heart muscle, the patient won't die, and the death is of less prognosis, less probability. So, this is how you can differentiate between an ECG of pericarditis and also MI. Very easy. Right. So that's the entire MI and ECG changes and the concepts behind the changes in the ECG due to MI. As I said, every change that we see in a disease and synchronizing with the ECG has a concept and also reason. And doesn't it look fascinating and beautiful learning medicine that way? Instead of just telling that you will have ST elevation and T wave inversion, mug it up. That's how it works. That's how you have to learn. That's how you have to remember. Go send the trophy. Then if it trophy is positive, then definitely it's MI. No, you have to know why it's like that. Why we are having trophy elevated. Why there is a T wave changes. Why there is PR segment changes. Why? All these why questions will actually make me more fascinating towards medicine, and that's why I have taken medicine and love towards medicine. We have reason for everything. There is a root cause and reason for everything. And next topic we'll be moving on to discuss is the erythemias, which is one of the toughest zone for many of you people. So let's see erythemias now. So we have an ECG here, and the first point again, even for the erythemias, I'll explain with the concepts only. Even though if you feel bored, you have to learn with concepts, because if you wanted to remember, you'll only remember that way, knowing the concept. Otherwise, if you want to mug up just by looking into a book in a theoretical book and saying ST elevation MI, ST elevation MI, ST elevation MI, then you will definitely not learn medicine that way. So let me talk about these erythemias and the concept behind these erythemias. Right. So the first thing, as our basic point, we have a heart rate. What is the heart rate here? Before I have to calculate heart rate, I have to know the rhythm as well. So is it, we have two and a half, we have two, we have three and a half, we have four, we have three again, we have enough. It is a irregular rhythm. It is a irregular rhythm. Then how we have to calculate the heart rate? Let us count the R waves: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 11, 12, 13, 14, 15, 16, 17. 17, and the heart rate is 102 per minute, and which clearly indicates a tachycardia, right? Tachycardia. The next thing is P wave. P wave. Is P wave present or not? I can't appreciate P wave anywhere. There is no P wave. Proper P wave. No. There is no proper P wave. P wave is absent in this ECG. And when P wave is absent, we can't appreciate the PR. Then first and foremost point, every one of you will learn in your coaching centers or in your respective apps, whichever you are using. If there is irregular rhythm, if there is tachycardia and P wave is absent, what is the answer? The answer is, I want to see that in the comments. I want to see that in the comments. Tachycardia, irregular rhythm, P wave absent. What is the answer? Blindly, every one of you will study, right? Mm-hmm. Atrial, atrial fibrillation. Wow. What if I say this is not atrial fibrillation and it is AVNRT? Do you know AVNRT also don't have P wave? So I will tell whether it is AVNRT or it is atrial fibrillation with a concept behind it. So let me talk to you whenever there is a problem, whenever there is problem anywhere in the valves, or whenever there is problem anywhere in the ventricles, right? Or whenever there is a problem in the aorta or arteries, pulmonary artery, then what actually happens is that there will be increase in the pressures in the ventricle. Okay, there will be left ventricle pressure increases, right ventricle pressure increases. Then what happens? There will be increase in the pressure also, right atrium and left atrium also. That's the basic concept. Every one of you will learn. Okay, we have pulmonary veins here. Okay, then we also have vena caval veins here. Okay. Now what happens is that these veins which are dumping into right atrium and the left atrium will actually have a automated electrical activity points. Automated, they generally don't get activated. Okay, they generally don't get activated, but they get activated whenever there is a major increase in the pressures in the right atrium, expanding the atriums, both the atrium, resulting in stretching the particular, automated electrical foci which are present there, and they will be sending activation impulses to the atrium. They will be sending activation impulses to the atrium. Listen to my sentence very carefully. They will be sending activation impulses to the atrium, right? So activation impulses from that foci. So whenever the atrium is getting constant activation impulses, activation impulses, the atriums, both the atriums will lose their ability to contract. Right, the saturation point, that's what we say. The threshold is completed and it says, I gave up because you're constantly irritating me by sending me impulses, and I give up on contracting. So when there is no LARA contraction, there will be, whenever there is no LARA contraction, there will not be having any P wave. These activating impulses which are present in the RA and LA will be stimulating the AV node and result in abnormal conduction or abnormal contraction of the ventricles. This abnormal contraction of the ventricles resulting in the irregular rhythm and also tachycardia. So that's the reason why in an atrial fibrillation patient will not have a P wave and will have a irregular rhythm and will have a tachycardia. And this is Atrial fibrillation. Now you can say, you said it can be AVNRT, and why not AVNRT? Okay, I will show you the ECG of AVNRT, but before I show you the ECG of AVNRT, I will explain you the concept. Then you can clearly know what I'm trying to explain here. So in an AVNRT, so there will be a circuit forming around AV node. That is why it is called as AV nodal re-entry circuit. AV nodal re-entry circuit. So it is present around the AV node. So it is constantly activating the AV node, constantly and repeatedly activating the AV node. SA node which is present is also activating the AV node. But before the AV node could sense the atrial contraction or the impulse which is coming from the SA node, this re-entry circuit which is having which is having two directions. One is fast conducting direction, another one is a short conducting direction. Then definitely it fails to recognize the conduction that is coming from the atrium, and P wave is not recorded on the ECG. But as the natural AV node is only being activated constantly, the rhythm won't change, the ventricular contraction won't change, just the ventricular contraction will increase, and the patient will be having tachycardia with the regular rhythm with the absent P wave. That's what the basic difference. Now I will show you the AVNRT ECG. You can clearly see, let me calculate the heart rate. As the AV node is being activated multiple times, the heart rate will be almost more than 150. 2 to 1 half, 2 to 1 half, 2 1 half, 2 1 half. So the heart rate is almost 150 per minute, and the rhythm is same constant because only the natural AV node is being activated, and it is being activated by a re-entry circuit just present at the AV node. No other extra circuits are present, no other extra impulses are coming or different impulses are coming from anywhere. So it is a regular rhythm. Then the QRS is normal and P wave is absent. That's the concept behind AVNRT and atrial fibrillation, and it is easier for you. With just 4 points, the heart rate, the rhythm, the P wave, and the QRS, we can diagnose it. And the next which comes is, right, the next ECG we can look into is that, yeah, so this is a different kind of ECG where we can calculate the heart rate, but quite difficult. Right, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. So it is more than 200 per minute. Right, it is more than 200, and it is very difficult to calculate heart rate in this particular because we can't differentiate what is P wave, what is QRS. Is that the QRS, the tall waves which are saying only the QRS? We can't differentiate. So, is the rhythm regular? The rhythm is also not regular. So, we have irregular rhythm, and we have a certain morphology of waves which are looking like so you say blindly you will be learning whenever there is sawtoothed waves with a tachycardia with irregular rhythm and P wave and PR interval not appreciated, but sawtoothed waves are present. Enough. What will be your answer? Then definitely you will be telling this is the sawtoothed waves, or we can say the flutter waves, which are usually seen in. I want the answers in the comments. Atrial flutter. We will say atrial flutter waves. But what is the concept behind this atrial flutter? That's what I wanted you to learn. That's what I wanted you to learn. So the atrial flutter, so this, what happens is that in an atrial flutter, there will be a re-entry circuit developing around the tricuspid annulus in a counterclockwise direction up to the cavo-isthmus junction. Okay, this re-entry circuit which I have drawn will constantly activate the atrium and the ventricle irrespective of the SA nodal, AV nodal function. So this circuit is the reason we are having flutter waves which is present around the tricuspid annulus, and this circuit has capability of striking at a rate of 200 per minute. So that's the reason you get flutter waves due to this one. That's atrial flutter for you. Right. We'll move on to the next ECG. Now, again, let's go on to the basics. So, what happens is that we'll be having a heart rate. So, what is the heart rate? Again, heart rate, one box, one and a half, one box, again, one and a half, one, two boxes, two boxes. It is clearly showing that the irregular rhythm is there. We have an irregular rhythm ECG, then what, how we can calculate the heart rate? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. So 21 is 6, somewhere around 126 will be my heart rate, and obviously it is tachycardia. Yes, now you have, can you see the P wave? Yes, I can see the P wave. I can see the P wave. Again, I can see the P wave. Yes, I can see the P wave. Now tell me, I have P wave, I have irregular rhythm, I have tachycardia. We have tachycardia, we have irregular rhythm, we don't have P wave. It is an atrial fibrillation. And if we have tachycardia, if we have regular rhythm, and if we don't have P wave, we said AV nodal reentry tachycardia. Now, what is this ECG? We have tachycardia, we have irregular rhythm, and the P wave is also present. Now, what is the answer? I want you to tell me in this. I want you to tell the answer. One second, one second. Screen not visible. Yeah, is it visible now? Okay, good. So let's move on. So this is nothing but multifocal, multifocal atrial tachycardia. But the point here is how to differentiate between this with some other tachycardia with irregular rhythm. So multifocal, so that clearly shows the origin of that tachycardia is different foci. So different foci resulting in different kinds of atrial contractions, resulting in different kinds of P wave morphology. The P wave, which you can see, is not the same. P-wave morphology is not the same in entire ECG. You can say, you can clearly see here, it is different here, it is different here, it is different here, and it is different here. The P-wave morphology usually changes, and So more than 3 P wave should be present in a in order to say multifocal atrial tachycardia, more than 3 P wave should be present, right? More than 3 P wave should be present with a heart rate of more than 100. We can say it is multifocal atrial tachycardia, and this multifocal atrial tachycardia is most commonly seen in a patient of COPD. Right, this is a straightforward bit which is multiple times being asked. They will be confusing you with atrial fibrillation, AV and multifocal atrial tachycardia, and this is how you need to diagnose it. And let's move on to the next ECG that I wanted to discuss. Right. Come on, this is what we needed. So heart rate. What is the heart rate here? So heart rate somewhere around 1.5 box, which almost is more than 200 per minute. And yes, the rhythm is regular here. Okay, regular rhythm, heart rate is more, P wave is present. P wave is present. Oh my God. Now what happens? Now we have to, P wave is present. Now what happens to the QRS? The QRS is narrow here. You can clearly see narrow QRSs everywhere. Everywhere we can see narrow QRS. Narrow QRS with P wave present, regular rhythm, heart rate more than 200. Yes, it is a possible diagnosis of orthodromic type of AVRT. What is AVRT? Atrioventricular reentrant tachycardia. And what is the concept behind this atrioventricular reentrant tachycardia is that so we have a SA node which will be activating AV node, right? Then this will be activating the AV bundle and bundle of his and right bundle branch, left bundle branch. But what happens is that we have a extra pathway or a re-entry circuit which is being activated, and this re-entry circuit will activate the AV node again. So this is activating this SA nodal activation of AV node and also re-entry circuit in an anterior direction. This is called as orthodromic AVRT. So another blinder is that any time SA node activating AV node and AV node activating the bundle of his and the ventricles are activated, definitely the QRS will be narrow or normal. And if SA node is activating some other electrical pathways in the heart and it is not activating AV node first, and the ventricles are being activated by that some other accessory pathway, then QRS will definitely be prolonged or broad QRS, I can say. So this is the one blinder point that you need to remember in order to diagnose these arrhythmias. So here we can clearly say a frontward direction orthodromic fashion. So we can say this is orthodromic AVRT ECG. And let us move on to the next one. So next one, we can also see the heart rate here is again more than 240 per minute, and we can also say that rhythm is almost regular again, regular again. So is the P wave present? That's the question. Yes, we can appreciate P wave at points, and at points we can't really appreciate the P wave as well. So I consider there is no P wave in this particular. Oh my God, there is a problem again. There is no P wave here. If there is no P wave and the rhythm is regular, we thought it can be multifocal atrial tachycardia. Sorry, we thought this can be AVNRT, but AVNRT will not have P wave. Uh, but we have our answer with the QRS. The QRS is broad here, but the QRS is not broad in the AVNRT, which is a differentiating feature. As I said previously, if SA node is activating some other SA node is activating the ventricles by some other pathway, that's when the QRS will be broad. That is, this is a possibility of antidromic type of AVRT. In an antidromic type of AVRT, thus re-entry circuit, this term is very important. There should be a presence of re-entry circuit in order to have a tachycardia, right? So SA node is here, we have an AV node, we have an accessory pathway. So this is activating here first, then the AV node is being activated and the circuit completes. So this re-entry circuit, which is activating accessory pathway early and forming a re-entry circuit at the level of AV node, there will be tachycardia with a broader QRS complexes, and this is an antidromic type of AVRT. Right. Next, we'll be moving on to the another ECG. So it's very easy. Whenever an SA node is activating AV node and AV node should activate the bundle of His, then only the QRS morphology will be normal, or if it is activating faster, the narrow QRS can be obtained. But SA node is activating some other accessory pathway and the ventricles are being activated, then we can clearly say that QRS is always broad. So this is a differentiating feature between AVRT, orthodromic and antidromic. Okay, so and in order to say orthodromic and antidromic, there should be a re-entry circuit should be present. This re-entry circuit is mainly responsible for causing tachycardia. Right. Let us move forward and look into the next ECG. So which is nothing but heart rate somewhere around 1, 2, 3, 4, 5 and 5.5, 5 and 5 and 5. I have 60 per minute, a heart rate and almost a regular rhythm, and I have a P wave, but P wave is present, but the PR is very short. PR is very short, and I can clearly see broad QRS is present. PR short and broad QRS. Right. So this is clearly showing that SA node is activating some accessory pathway. If SA node is activating an accessory pathway, we say QRS, but if there is a re-entry circuit, we'll have a tachycardia, but the patient is having almost bradycardia, then definitely it is not AVRT and it is not AVNRT. Then what it is? This is WPW syndrome. So in a WPW syndrome, the accessory pathway being activated by the SA node first than the AV node, which is activating the ventricles or Purkinje fibers first before the bundle of His activates. So now what happens is that as the atrium contracts and the contraction wave straight away moves on to the axillary pathway, the PR is shortened and we have and the accessory pathway is activated, and I said bundle of His is the fastest conduction pathway in the heart, but here accessory pathway is being activated, which is a slow conducting, as it conducts to the Purkinje fibers, which is also slow conducting. The QRS will be slowly moving and raising, and by the time it connects with the bundle of His or the bundle branches, we get the normal R wave, and this is called the delta wave appearance in the WPW syndrome. So we have the classical appearance of WPW syndrome is PR short due to early activation of the ventricles, and broad QRS is also present, and the P wave is present, regular rhythm, and heart rate is less because there is no re-entry circuit, which we can differentiate from AVRT, and this is the WPW syndrome. Next, we'll be moving on to the next ECG, which is important for you for your exams. And here, heart rate is again more than 200 per minute, almost to 240, 250, and regular rhythm. And the P wave, we can't clearly see the P wave here because the broad QRSs are present, broad QRS complexes are present, but tachycardia is present. As I said, if SA node is not activating AV node and AV node is not activating bundle of His, then we will have a broad QRSS. But here we can't appreciate the P wave, which might be submerged into the QRS. But what is the reason for the broad QRS here? The reason for the broad QRS here is mainly due to the conduction, automated conduction circuits which are developing in the ventricular myocardium itself. That is the reason we are getting so many QRSs in a shorter interval, and this can be our ventricular tachycardia. Right, these are just an automated electrical circuits, electrical inputs, or we can say electrical inputs coming in the ventricle itself. That is why ventricular tachycardia is being developed, which we can see in an MI patient again. We can't clearly appreciate P. We can't clearly appreciate PR. It can be overlapping with it. If here again we can see, but it's getting overlapped. Okay. Next we can have the ECG. Heart rate is again more than 200 per minute. And we also have, we can't say the rhythm is not being appreciated, but it is almost having an irregular type of rhythm only. And the patients, can we see the P wave? No, we can't anywhere appreciate the P wave. We can only see the QRS complexes, which are broad again. P wave absent with QRS being broad. With QRS being broad, Q and P waves being negative and slightly looking like almost ventricular flutter waves. Ventricular flutter waves, but yeah, so this, the reason why here the waves are like this is that in a ventricular myocardium, the re-entry circuits are being developed. So this re-entry circuits are responsible for the development of this kind of waves, looking like a fibrillar waves with absent P. Fibrillar waves are mainly due to development of fibrillary waves, which are mainly due to the re-entry circuits within the ventricular myocardium. And this is a possibility of ventricular fibrillation. Both ventricular fibrillation and ventricular tachycardia are commonly seen in a MI patients. Right. So this is one more important ECG that we have to learn, and we'll be moving forward with next ECG here. Heart rate. Oh my God! Again, we have a typical ECG with different tall dinosaur waves here. What are these discordant dinosaur waves? These are nothing but PVC, premature ventricular contractions due to some problem in the ventricles, either due to an artificial fibrotic foci being developed in the ventricles. Sometimes a conduction abnormality can be clearly seen, and which we can see on ECG as this morphology of QRS, and those are nothing but premature ventricular contractions. So with that, the arrhythmias are almost done, and we have come on to the last and final topic. That's nothing but the blocks. So we have, when it comes to the AV blocks, the blocks, AV blocks are first degree block, second degree block having Mobitz type 1, Mobitz type 2, and then we also have 2:1 block, and we have a complete heart block. And I will try to explain it before I show you the ECG. So first, let me talk to you about the first degree block. So first degree block. So when we have a first degree block, it is nothing but we having a prolonged PR interval. So any AV block, the blinder you need to remember again here, any AV block, the problem is mainly not SA node or AV node. The problem is mainly in the conduction from SA node to AV node. That is the conduction defect from the SA node to AV node, or AV nodal delay, or AV nodal conduction delay. So the conduction delay is there, or AV nodal function dysfunction is there. That is how we can clearly say in a primary block there is a prolonged PR interval, prolonged PR interval, right? Prolonged PR interval constantly. When it comes to the second degree block, and in second degree block we have Mobitz type 1 and Mobitz type 2. So in Mobitz type 1, what happens is that we have a prolonged PR interval, but this prolongation will be increasing with every next wave. That means there will be a progressive or gradual prolongation of the PR interval and sudden dropping of the wave. Again, there will be there. So sudden dropping should be there, and there should be constant PR prolongation should be there. So which can differentiate it from the first degree block. So this is Mobitz type 1. When it comes to Mobitz type 2, we have the PR will be either normal or prolonged. either normal or prolonged, and sudden drop of the wave for sure. So it can be the PR, there is no progressive increase in the PR interval. There is no constant PR prolongation. It can be normal or it can be prolonged. It can be normal or it can be prolonged. But the differentiating feature of Mobitz type 2 from Mobitz type 1 and also first degree block is that we have cluster of waves at one point. Cluster of waves. So which is a one differentiating point you can clearly identify and mark the answer in the exam. Right. Next, 2 is to 1 block. Many have asked me, they have got confused with the 2 is to 1 block. There is nothing to worry. One basic point I will tell before I could draw and show. For every second wave, one wave will be dropped. Again, I'm telling, for every second wave in the ECG, one wave will be dropped like this. For every second wave, one wave will be dropped. So you can clearly see this is the second wave and one wave is dropped. This is the first wave. This should be second, but one wave is dropped. One wave is dropped. So for every second wave, one wave is dropped. That is 2 is to 1 block. Very simple. So that is second degree block. The second degree block is mainly due to the problem in the AV node, AV nodal conduction or AV node itself, right? So before I go into the last and the final third degree block, let me show you the ECGs here of the first degree, second degree, Mobitz 1, Mobitz 2, and also 2 is to 1. So you will clearly understand. So in this ECG, if I have to show, see, I told you the P and PR interval should be half of the large box, but here you see it is occupying almost one and more than one box. So the PR prolongation is there, but not gradual prolongation, constant PR prolongation. This is a high chance of first degree block. Associated with it, there is also tall T wave taking the ST along with it. This is also an ECG of anterior MI. So in an anterior MI, we can also see first degree blocks. There is a possibility. There is a possibility that we can see first degree blocks. So this is how you have to diagnose with PR prolongation being constant, right? Next, we have next ECG. Again, I'm just fastening up because it's almost more than 2 hours 20 minutes. But in any ECG, always go with the same method: heart rate, rhythm, and P wave and QRS. That's how you can actually diagnose any kind of condition through ECG. So here you can clearly see if as it is an AV block, I have to look into the P wave. It's PR interval is okay, normal here, slightly prolonged, more prolonged, drop. So as I clearly said here, prolong and drop is a 2 is to 1 block. Sorry. Mobitz type 1 block of second degree Mobitz type 1 block, second degree block, and Mobitz type 1. Second degree Mobitz type 1 block. Simple, right? Then we have the next ECG. Here, the PR is same. There is a drop. There is a drop here. PR is same, but I can find a cluster of waves. As I said, there is a cluster of waves, PR being constantly normal or can be prolonged, but normal. I mean, constantly normal, and we have a cluster of waves and a drop of one wave is being dropped. Then definitely it is a Mobitz type 2 second degree block. Mobitz type 2 second degree block. Yeah, there is a cluster here also, but there is prolongation of the PR. No, just think once. Right. So the next we can clearly see, I have to see the PR. Okay, there is PR present, but here there is no QRS. There is PR present here, there is no QRS. There is PR present here, there is no QRS. As I told, for every second wave, one wave will be dropped. That pattern is being followed here. So this is nothing but 2 is to 1 block. So if you want a concept here, for every second SA nodal wave to reach AV node is not being conducted into the ventricles. That is why one wave is being dropped. So the defect is in the AV nodal conduction pathway. Okay, that's why this is a 2 is to 1 block. Don't need to get confused. It's very easy. AV blocks are most easy, right? Let's move on to the next ECG. And here I can see P, 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 and this looks like a QRS, P, 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 and QRS. So what about this? So here, complete heart block. This is nothing but a complete heart block where we can see AV dissociation, atrioventricular dissociation, AV dissociation. AV dissociation is usually seen here. So what happens here is that the atrium will function like however they wanted, and the ventricle will function however they wanted, because SA node will conduct to AV node, but AV node is not functioning properly. The conduction system is not functioning properly. The Purkinje's are also not properly present. Entire conduction pathway of the heart has been damaged, resulting in complete heart block, and there is a high chance the patient might end in a systole in complete heart block. Atrial rate varies and ventricular rate also varies here. It's irregular and we can't exactly find the heart rate. So that's it about the blocks. We have discussed primary block, secondary block, and also tertiary complete block and secondary block, Mobitz type 1, Mobitz type 2, and also 2 is to 1 block. And that sums up the entire ECG class, and it's almost 1.5 hours. I know it's pretty long, but I have to explain the concepts before I can explain the ECG to you. Without knowing the concept and without knowing the basics, that basic changes that happen due to the electrolytes or that happens due to the underlying pathology, you can't really interpret an ECG. You have to know all these features before we can interpret an ECG. I think this have helped you a lot. If you have any doubts, I'll stay for 5 more minutes. Here you can ask me. I'll see the comments anywhere. If you couldn't understand in the entire class, you can ask me, and you can also correlate with the notes that I have given. I'm pretty sure that's the best ever ECG notes that you can get, even for the UGs, for the interns, for the PG aspirants, for the PG residents also. So just go through that notes. That's the free notes that I'm going to give you for all. Yeah, just ask me questions if you have any doubts regarding any ECGs. So I think that's how medicine should be dealt with all roots, analyzing the basic concept, knowing the primary points before we get into the depth, not blindly thinking that why tall tentative wave should be seen in hyperkalemia, that's it. And you can't mug up that way. You have to know the concept why there is tall tentative wave due to hyperkalemia. I think everything, yeah, pericarditis was MI, concave convex yeah, I have clearly mentioned when we are talking about the convexity in an MI, there is a transmural involvement is there. So we don't have any good myocardium available for the proper conduction. Whenever there is the collaterals are also not exactly ready. So the vector which is present will be in the same direction but in the upward direction. So it tries to get along the damaged one, so it goes in an upward convex. But what happens with the pericarditis is that the good ventricle will be available for us. So till then it is very much normally present, and when it goes to the pericardium, it tries to move away. I'll show you the image which I have drawn so you can get to the point. Yes, here. See. So the current which is coming is trying to escape from the pericardial inflammation. So it dips down as a concave wave. LVBB, RVBB is, no, it's almost easy because bundle branch blocks will be there whenever the bundle branches are being damaged. And you always remember, however I explain, you always remember as Marrow and Williams, right? I think that's the best way to remember the blocks also. But blocks are always associated with SVTs or any kind of arrhythmias reasonably. So remember Marrow and William, that is enough for you. So please next one more class on acid base. Okay, ABG. We'll see. You have very less time actually for the exam now. Talking about ABG, because ABG will have 4 to 5 conceptual levels which can actually confuse you. But I'll try. If more people ask me about ABG, that more people are interested in knowing about ABG, then definitely I'll take a class. But not so long. Maybe up to 1 hour, 45 to 1 hour. Any more questions? Any more questions? 2 more minutes and we'll end the stream. Uh, if any more questions, okay, thank you so much. Thank you so much for staying with me more very patiently till all the way. This will definitely make your concepts in ECG stronger, and you shouldn't be afraid and start panicking if someone asks to ask you to interpret the ECG. Just follow the basic points, and you'll definitely get a diagnosis. Look into more number of ECGs. You'll be habituated with it. And I have to thank one of my inspiration for learning the ECG and cardiology in such a way. And thanks to my idol and inspiration, Srikiran sir, I always stay gratitude for him for bringing all the inspiration to get me to make me take medicine and making the cardiology so interesting for me. Thank you so much, sir, and thank you people for making this session a wonderful one. And don't forget to like, share, and subscribe to Dr. JTM. And I'll be back with one more fantastic video. Until then, bye. All the best. Prepare well. Don't panic.